Hi, Mike Gibson, Manesh Patel. We're talking about the early termination of one of your trials, Manesh, looking at a new novel Factor XI inhibitor in patients with atrial fibrillation. Talk to us a little bit about what you can say publicly.
Yeah, well, first, Mike, thanks for letting us have the opportunity to have a conversation. And, I'll just say, importantly, we want to start by thanking investigators, patients, Bayer, who helped support the study, OCEANIC AF, and others to say we have to do randomized controlled trials to improve the field of medicine. And that involves finding patients that have an unmet need. And we still have 50% of patients or 40% of patients in some of our areas that don't get the right dose of a DOAC or an anticoagulant or don't get treated with atrial fibrillation, significantly because of concerns of bleeding. So, like a lot of people, we hypothesized that one of the Factor XI inhibitors, Asundexian in this case, would hopefully be non-inferior and or superior regarding efficacy and also reducing bleeding. I won't, reserve judgment on talking about the findings of the study. We just know that the IDMC recently met and recommended stopping the study to ensure that patients can safely get back onto oral anticoagulant therapy.
Now, Manesh, one of the things that's been said online, and I want to give you the chance to address this very squarely, is wow, there must have been a big difference there because the study started, pretty recently. There must have been a big difference in outcomes. Talk to us a little bit about, maybe tempering that sentiment.
Yeah, I think people should reserve judgment until they've seen all the data. I'm not suggesting by any means that the IDMC didn't make a good decision. I just want to be clear that it's always hard to not speculate because we're just humans and we want to know. But I will say that certainly they should reserve judgment till they've seen the data. And they should know that we've learned over the last several years on how to do these trials to hopefully enroll patients at a larger number and get many more patients in so that hopefully we get to answers faster. And I think partly that's what we're learning to do. And I also want to highlight for people that this was a bold proposition, studying a new oral anticoagulant small molecule for Factor XI against apixaban in this case, but a DOAC. And so this is active therapy. This is randomizing against things that work. Those are important things to do. There are still opportunities, importantly, in areas like secondary stroke, ACS, other compounds, other AF areas that people are certainly studying and we should continue to follow. And they're different compounds with different mechanisms. So it's important to think about that too.
I do think you're right. The good news is these studies in this area are enrolling very rapidly. And I do think it's important what you're saying, that we can get the question answered more rapidly these days. Is apixaban really the comparator that should be, used in these trials? I mean, is it best in class in terms of safety?
Well, I don't know if it's best in class as much, but once somebody believes it's best in class, and I think that's a large belief in the space, then if you want to, have new therapies, then that's what you should do. I would say, for example, certainly the rates that we're seeing with some of the bleeding in apixaban and Aristotle were lower than other trials, but that may be a patient-based risk. And so patient risk drives a lot of that. We've also seen with the doxaban 30, for example, a dose that had a lot less bleeding. Again, there are other therapeutics. And again, I would say, although I participated in rivaroxaban at a certain dose there, especially in the older patients with renal dysfunction, has a pretty good profile. So I don't know that we know which one. In fact, we'll get into an era where maybe some of these are going to be tested against each other, but we don't know which one has the best-in-class bleeding profile. However, I think each of these trials have to take at least what they think is a reasonable comparator and go forward if you're going to be in a place where patients can tolerate atrial fibrillation anticoagulation.
And there's always been some discussion about how major bleeding was defined. With the apixaban, there's been discussion about how it had to be an acute drop, not a long, slow bleed like what you included in rivaroxaban. So it's really hard to compare across trials between.
Yeah, I think that's a really, sorry to interrupt you, but I think it's a really important point. Even though there's an ISTH major bleeding definition, and these definitions are the same, how you actually operationalize those, and especially how you have older patients that may have hemoglobins that slowly drift between clinic visits, and whether or not that becomes a GI bleed because it drifted, and then they get a colonoscopy and they're found to have a polyp. That's an important conversation. It may not have always been seen the same in all the trials. So I do think people should be cautious about making too many broad judgments. Secondarily, I also think people should use the evidence base, which is the dose of the drugs that were studied at those populations.
So you're continuing, though. I think it's important to point out you're continuing in your stroke trial. Talk to us about that.
Yeah, I think it's important to recognize that oceanic stroke is open enrolling in patients or were reviewed by the same IDMC, and they had no concerns and said, please continue enrolling. Remembering there, asundexian, the small molecule, is being compared against placebo on top of standard of care in patients who've had a stroke and have obviously unmet need. And so I think it's important for people to recognize that there's still significant unmet need and opportunity with this therapeutic in that indication. And certainly for the field of Factor XI inhibitors, both in this specific indication, the secondary stroke, and others, because again, there's a lot of reasons, and we're still just learning the data. You know, we're a week and 10 days into this. We're working and focus strictly on getting patients safely transitioned onto anticoagulant therapy, and then bringing in patients, getting all the data, and then as rapidly as possible after our executive committee and others have reviewed it to get the information out to the public.
And it's important probably to note that the IDMC did not recommend any changes to the dosing in the stroke trial. I mean, is one IDMC overseeing both? And
yeah, it's important to recognize that there is one IDMC overseeing both studies and has been looking at the data for quite some time, as was done in the phase 2 studies for this compound and this program, like in other programs. And so that's valuable because that IDMC and some members across phase 2 and phase 3 have been looking at this data, have knowledge of the compound. And so they have no recommendations for changes, continue on with the oceanic stroke study as is, which is what's going on.
Great. Well, Manesh, thanks for joining us. Listen, you know, you ask an honest question, you do an honest trial, you get an honest answer. Well-designed study, well executed, giving us an answer quickly. Great job. Congratulations.
Yeah, well, thank you. And again, when things don't always move the field forward, we're often saddened. We feel bad for our patients. We have hope, but I want to make sure everyone understands we're very appreciative of all the investigators and the patients. And this is how we learn in medicine. And we appreciate everybody participating.
Absolutely. Thanks, Manesh.